Welcome, everyone. I'm Laura Erskine, co-director of the UCLA Center for Healthcare Management and faculty in the UCLA Fielding School of Public Health in the Department of Health Policy and Management. On behalf of the center and the UCLA Fielding School of Public Health, thank you for joining us. Before we begin tonight's session, I want to thank the many donors who make this program possible. We are deeply grateful for your support. As many of you know, this program is named in honor of Paul Torrens, now Professor Emeritus at the Fielding School. For more than 40 years, Professor Torrens has guided, mentored, and advised students at our school, helping many to shape distinguished careers in public health. A few housekeeping notes before we begin. We encourage questions from the audience. You can submit questions at any time by clicking on the Q&A button near the bottom of your screen. We will take questions as time permits towards the end of the program. There will be a link to the moderator and panelists' bios in the chat, and you can also scan the QR code that's on the screen or type in the URL that you see at the bottom. We are honored to have with us this evening 4 distinguished experts. Our moderator, Randall Kuhn of the UCLA Fielding School of Public Health, as well as Ricky Bluthenthal from the Keck School of Medicine at USC, Margot Kuschel of Zuckerberg San Francisco General Hospital, and Medell Briggs-Melanson from the UCLA Hospital and Clinic System. It's my pleasure to get tonight's program started by welcoming Randall. We're thrilled to have you with us tonight, Randall.
Thank you so much, Laura. I'm unmuted now. Welcome, everyone. I'm so pleased to be part of this exciting but challenging panel. I'm also pleased that we got such an amazing panel of speakers. I'll note all of them are practicing physicians who have incredibly busy schedules treating patients, in addition to all their scientific and administrative leadership work. So thanks to them. I just wanted to motivate the panel just really quickly with some quick, just throw out some numbers, basically, and maybe a provocative idea that explains some of the, I think, fairly sudden move of a large number of health plans and health service providers into the space of homelessness. That is, providing more services directly to patients on the streets, and also providing a broader range of services. And I think we'll get a lot of background on that. But I think the basic notion behind all this is this one I've highlighted at the top of the slide, that homelessness is a medical condition. And I don't want to say definitively that homelessness is a medical condition, but I think the argument I've made lately is that it can be helpful heuristically, and it can be helpful in terms of how we pay for things and how we think about things to treat homelessness as a medical condition. Now, it can also reduce homelessness to just, I don't want to say that it's just a medical condition. It's many other things. But the logic that I just want to throw out is perhaps best summarized without any numbers by my friend and colleague Coley King, who is a pioneer of street medicine and director of homeless medical services at Venice Family Clinic. And he puts it pretty succinctly, right? Diabetes cuts about 8 years off the average life expectancy, but homelessness takes more like 20 or 30 years. And diabetes is a complicated one, right? It doesn't just target life expectancy directly. It reduces life expectancy through a large number of comorbidities, and homelessness operates in much the same way. So just to throw out some quick numbers, for infectious disease, again, we don't have very good evidence, very good gold standard evidence on what the health risks are associated with homelessness, but a lit review that some UCLA School of Public Health students and I conducted suggests, and this is building, in fact, a lot on the work that work by Margot, suggests, right, that the relative risk of hepatitis B is 3 times higher for people experiencing homelessness than the general population. HIV, 10 times higher. Hepatitis C, which has untold consequences and costs for treatment, 16 times higher. Tuberculosis, you can hardly, it's even difficult to count the relative risks. Oh, can you go back again? Sorry, Laura, if possible. And then I just wanted to know back to the one ahead, that's not that important, the chronic disease. It's just to say that it's relatively easy to think about all the ways in which homelessness affects infectious disease, but we also want to keep in mind that homelessness has devastating effects on chronic disease. And that is, I think, Professor Kuchel's research sort of highlights that one way to think about homelessness is that it causes aging on fast forward, right? That a lot of the evidence coming out of her work and other people's work suggests that if you look at medical conditions or surgical complications or mortality from chronic disease, people experiencing homelessness, especially for a long time, may have the health conditions more typical of a person 10 to 15 years older than they are. You add on to that treatment of chronic diseases, like especially motor diseases like MS, Parkinson's, Huntington's, are almost impossible to treat without refrigeration and constant provider contact. Add on to this on the next slide, that the homeless population is aging very rapidly, right? That right now people experiencing homelessness are younger than the general population, but that is changing very quickly as baby boomers age through age into the over age 65 group. Right? The baby boom cohort, especially those born 1955 to 65, have experienced adversity throughout their lives. So much that a recent study using health and retirement survey data suggests that 6% of adults in the baby boom cohort have experienced homelessness at some point in their life. And right, it's easy to look at numbers like 60,000 people experiencing homelessness in LA in a single point in time and say, well, that's a pretty small number. But if you add that up over a lifetime, 6% of baby boomer adults have experienced homelessness. And then when you look at African-American baby boomers, it's up to 17%. And so the burdens affecting that population are only going to rise as the population who are homeless and over age 65 triples between 2010 and 2030. Next slide, please. Again, just another set of numbers. I've done a lot of work on COVID-19 and homelessness. Shortly after the pandemic, sort of the first couple waves of the pandemic, I think there was an idea that people who were homeless in Los Angeles didn't do that badly with COVID-19. There were a couple stories in the LA Times published on this notion. This is simply not true. First of all, what they mean when they say that is that people experiencing homelessness in raw, crude numbers were no more likely to die than the general population, which is not that it was better, simply that it wasn't much, much worse, as with other diseases. But beyond that, once we account for age distribution, what we see is that a homeless person between age 30 and 50 in LA County was about 4 times more likely to die from COVID-19 than a housed person of the same age. And sorry, these numbers didn't quite come out right. For people aged 50 to 64, it's twice as likely. For people over 65, it's more than twice as likely. And again, what we see is that if you're 50 years old and homeless, you had the COVID-19 risk more typical of a person 60 to 70 years old. The last point I just want to make to motivate all of this is to highlight and we can go to the next slide, is just to highlight the role, the broader context of mortality, which is deaths among people experiencing homelessness have been rising rapidly over the past few years, and that rise further accelerated in LA County in 2020, and we've also seen comparable rises in other cities in California. And then the last slide, I just want to tie this back to race disparity. So in LA County, 9% of the population is African American, 40%, 30 to 40%, depending on how you count, depending on whether you're talking about homeless at any given time or homeless in the course of a year of that population, of the homeless population, are Black. In San Francisco, Margot, we were talking before this session, the numbers are even worse. So 5% of the population is Black and 37% of the homeless population. So homelessness is driven in large part by histories of racial disparity in the housing market, in employment markets, and of course in the health system itself. With that, I will pass things over to Ricky Bluthenthal, who will give us a much deeper dive into the context.
Hi, thanks. It's good to be with you all. This is my second Torrens forum. I moderated a couple years ago on a session on prescription opiate challenges we're facing. Tonight, I'm going to just summarize a little bit of the most recent data from the 2020 homeless count in Los Angeles. And there's a link to the presentation where you get the original data, and then talk a little bit about substance use and being unhoused based on research that I've been doing over the last 30 years among people who inject drugs. Next slide, please. Oh, and by the way, I'm not a physician. I'm just a simple country sociologist. So, but I am very busy. Okay, so in Los Angeles, a lot of our housing problems are driven by a lack of supply, particularly of affordable housing. So it's estimated that Los Angeles needs another 509,000 affordable units. It's also, as Randall pointed out, homelessness disproportionately impacts African Americans. And based on the latest the data from 2020, about 34% of the people experiencing homelessness in Los Angeles were African American. And then just finally, even though you know we've had increases in the minimum wage, the pace of property values and rental costs have gone up much higher than the pace of wages. So even as the county is succeeding at housing, depending on who you ask, 20 to 30,000 people every year, we're still creating 30 to 35,000 new unhoused people. Next slide, please. And then I just want to highlight some of the issues of how people get there. So a fair bit of it is driven by domestic and intimate partner violence. Next slide. And then in terms of substance use, I want to just emphasize that, of course, most people who are unhoused do not use substances and would not be classified as folks with substance use disorder. But the intersection of substance use and homelessness gets a lot of political attention. And so I'm going to try and break down some of that in the next set of slides. Here, just note that, you know, generally about a quarter of the people report having a substance use history. There's also about a quarter that have serious mental illness. And when you combine those two, you get about 40% of people either have severe mental, illness or substance use disorder in Los Angeles. Next slide, please. Okay, so I'm sorry you can't see all of this. There are ways in which drug use contributes to homelessness, and then ways in which once you're homeless, you're more apt to use substances. So I just want to make the point up front that a lot of homelessness that we have in our country is driven by structural problems. So there's a sort of economics of our markets and our housing markets in particular, but also our approach to substance use disorders and the use of the criminal justice system as some kind of tool to address that has resulted in people having diminished life opportunities. So if you spend time in jail, you are more likely to become unhoused. And if you have a drug felony, there are a whole range of both federal, state, and local services that are not available to you. And there's efforts to change some of that. And obviously with the legalization of cannabis, there's some expungement going on of records related to people arrested for cannabis use or cannabis sales. But you basically, by putting people in jail for using substances, you significantly diminish their chances to have the kind of healthy lives we'd want for people. And then, of course, when people become unhoused, they're subject to both psychological indignities and physical injury and mental health disorders because of the how difficult it is to be unhoused. They're more vulnerable to violence. They're more vulnerable to other kinds of exploitation. And we see even in my samples, people beginning to use methamphetamines more as a strategy for staying awake at night, so that they don't, so that they're not harmed as a consequence of not having a place to stay. And then lastly, if you're unhoused, you're then exposed to a lot more substance use, and exposure can contribute to people initiating use. Next slide, please. So I'm just showing you some data from my 20 years of collecting data among people who inject drugs in community settings. And I'd just like to point out that in most of the neighborhoods that we routinely collect data from participants, the rates that report being unhoused has gone up substantially over time. And again, I think that has to do with the market, that has to do with the war on drugs, sort of driving people into situations where they're not housed. Next slide, please. This is data from our sample in 2016 and 17, and then I'll talk about the data that we collected in 2021. So about 80% of that total sample was unhoused. They had been unhoused for a long time. So the mean was 26 years. The median was 28. In the last 6 months, 3/4 had belongings stolen, 33% had been assaulted, and 13% of the women had been raped. And then they have disproportionate encounters with security guards, police, and about a little over a third had been arrested. Next slide, please. They're also moving around a lot. So we've begun collecting more detailed information about how often people have to move, whether it be encampments or moving between houses or moving between shelters. And I just want to emphasize a point that, you know, there are 170 people on this call, so there's a diversity of people. But for most of us who have remained housed steadily, probably most of your life, like I have, I've never been unhoused. I want to emphasize this level of disruption is an independent variable in causing health harms for people. And I'll show you some data that reinforces that point shortly. Next slide, please. So we've been collecting data in Los Angeles and Denver since May 2021. So we're still collecting data in COVID. We're doing it outside and safely. No one's gotten COVID. What we've tried to do is begin to ask people whether they're housed or unhoused. If they're unhoused, how often are they moving? And then I broke that up into a couple of different variables and then created logistic regression models to look at whether it predicted some health risk. So this first group, the first 2 columns are about self-reported non-fatal overdose in the last 3 months. And you can see the categories. So we compared people who were housed to people who were unhoused and didn't move to people who were housed and moved. And you can see, I'll just interpret that. So basically the odds ratio is 4.3. That's significant for people who are unhoused and moved. So they're more likely to have a non-fatal overdose if they're having to move. They're both unhoused and having to move. And then similarly looking at receptive syringe sharing, which is the way in which people become HIV infected and hepatitis C infected. Both being homeless is an independent predictor of that, and being unhoused and having to move. So part of the policy response to homelessness in places like Los Angeles and other places where we want to get the encampments moved, we're actually, not only are we not getting people housed, we're literally harming them. We're making their lives more difficult, and that results directly in diminution of well-being. Next slide, please. People lose important medications and other things that you need to have a dignified life, including access to clothes. So over 90% had lost clothing during encampment cleanups. They'd lost food, and food insecurity is rampant in this population. About 60% report food insecurity. People had lost syringes, so that's contributing to the syringe sharing. And then this last one, this darker blue one at the end, people are actually losing Suboxone, right, or buprenorphine, which is a medication that people use to treat opiate use disorder. So again, this policy of removing the encampments may be satisfying to housed individuals who seem to be the main constituency calling for them. They are directly making our problems worse. They're making problems worse for the population that is directed at immediately. Next slide, please. Then I just want to close with a few last thoughts. maintaining adequate hygiene, having supportive peer relationships, having contact, being able to stay in contact with outreach workers, all of this is disrupted by these sweeps of the encampments. But it also it's traumatizing to people. We're directly inhibiting the capacity of them to build the self-efficacy and self-worth they would need to improve them circumstances by this sort of draconian approach to people being unhoused. And of course, in Los Angeles, our unhoused population, 80% are unsheltered as well. So I get that it can be unsightly and problematic, but removing the encampments without getting people housed, without providing additional services, literally makes the problem worse over time. Next slide. And so that's why, and this is just a quick report of a meta-analysis talking about the relationship between housing and infectious disease spread. And this meta-analysis just finds that, HIV risk and hepatitis C, both HIV incidents and hepatitis C incidents are increased among people who are unhoused. I think I have one more slide. Okay, so, folks need more social support. They have complex needs that are left out of the current health system. We need to establish connection and constancy, and we need to stop disrupting their lives so they can be in a position to benefit from some of the services that we're trying to provide to people. Thank you for your attention, and I look forward to the moderated discussion.
Hi, I'm Margot Kuchel from UCSF, where I'm professor of medicine, and I direct the UCSF Center for Vulnerable Populations and the BNF Homelessness and Housing Initiative. And I was asked just to provide some background on harm reduction, housing first, outreach, and engagement. Next slide. So what is harm reduction? Harm reduction is an evidence-based, client-centered approach to reduce the negative consequences of behaviors, often in referral to substance use, also used for sexual behaviors or other behaviors. Next slide. Important to note that harm reduction does not require that people abstain or stop using or engaging in the behavior, but rather provides people with choices to minimize any harms associated with those behaviors. Harm reduction uses a non-judgmental and non-coercive strategies. Next slide. And it really meets individuals where they are at and then works to promote incremental change. Next slide. So some basic principles of harm reduction. Harm reduction, particularly with respect to substance use, accepts that drug use is a part of the world and it works to minimize the harmful effects. It understands that drug use encompasses a continuum of behaviors. Some of the ways are more harmful and some are safer. It establishes that the criteria for success is not abstinence, but individual and community well-being. And it really calls for non-judgment and non-coercive provision of services and resources. Next slide. You may have heard of Housing First. There is an awful lot of chatter about it and an awful lot of misconceptions. Housing First is an approach and not a program. So anyone who says Housing First is this or isn't this when they're talking about a program is probably not talking correctly. Housing First is an approach that prioritizes providing a permanent housing to end homelessness. And it really, at its fundamental, recognizes that housing is a necessary foundation on which people build their lives, on which people heal. And it really recognizes that people need basic necessities met before attending to other issues. Housing First recognizes the importance of client choice. And Housing First, very importantly, does not require sobriety, participation in treatment prior to or during housing, and does not require people to graduate housing by proving themselves. Next slide. Housing First is the federal policy through the HERTH Act in 2009 that all programs that use federal resources need to adhere for housing for homeless populations should adhere to Housing First. Why was this a federal policy? Not that it was sort of some radical idea, but because there was a growing and has since grown enormous evidence base to support it. Housing First is not just for those with the highest needs. So you've probably heard of Housing First most commonly in the context of permanent supportive housing, which I'll talk about in a second, which is the evidence-based way to provide housing for people with chronic homelessness and behavioral disabilities. But it's also all of our other sort of housing policies like rapid rehousing, which is often used for families or people newly homeless, where people are given transient, usually up to 18 months of a rental subsidy plus some services, also are offered on Housing First principles. In the old days, we used to do this housing sort of ladder where people would be offered shelter if they could be quote unquote sober or sometimes use clean. I hate that word. And then frankly discharged if they couldn't adhere to those rules. If they did adhere to those rules, they might be offered 2 years of transitional housing. If they followed all the rules, they might be offered permanent housing. That was not successful, and it left many, many people homeless because of it. Housing First really inverted that and said it's impossible, we know, for people to actually work on their sobriety, work on their behaviors while they're trying to figure out where they're going to sleep at night. And that instead we need to flip it, start with the housing, and then start to engage them in other activities. Next slide. So what is the evidence for Housing First? There's a strong and growing evidence base. And I want to focus on the strong and growing evidence base for housing people with severe behavioral health disabilities, because those are the folks that I think garner the most press attention and the most concern. There have been repeated studies, including one that I recently did in Santa Clara County, throughout Canada, in Denver recently, in France, it just came out last week, showing that even those with the most significant disabilities, more than 85% can be housed long-term if they're housed using Housing First principles with permanent supportive housing. In our study in Santa Clara, we purposely identified the 400 highest risk, most behaviorally challenged, chronically homeless individuals in the county. These individuals had an average of about 19 ED visits or emergency room visits in the prior 2 years, about 5 or 6 jail stays, as many hospitalizations, and multiple psychiatric ED visits just on average. And what we did was we met them where they were. We put flags in their chart. We knew that they would show up. And when they showed up in jail or in the ER, we would approach them and say, do you want a 50-50 chance of being housed? We only had enough housing for about 125 people. All but one person who we approached in the 7 in the morning after they'd been up all night said yes, they wanted a 50-50 chance. We randomized them on the spot because again, we had limited housing. Those who got randomized, by the time we finished, 91% were housed. When we published our study, 85% were. And we followed them now for 6 years, and they spent over 90% of their nights housed since that first approach. I want to emphasize that we approach the most behaviorally complicated folks. These are the folks that every police officer knew, that every emergency department nurse knew, and successfully housed them all using this principle. They had a small team of outreach workers who followed them into housing. It was led by a master's trained clinician with a peer and a bachelor's trained case manager with a 1 to 15 ratio, meaning that that team of 3 would have 45 clients who they went out to, when they met them in the ED, they followed them into encampments and things, they brought them into housing and then stayed with them. Housing First and permanent supporting for it to work must have no preconditions. There was no requirements to engage in treatment. But what has been found in our studies and otherwise is if you offer people the housing and make the services easy to access, people will access the services and decrease their harmful use. It involves outreach, engagement, and ongoing support. Next slide. For outreach and engagement, when we think about providing medical care or healthcare out to people who are experiencing homelessness, the important thing is that those services need to meet people where they're at. As 2/3 of the homeless population in California is unsheltered, this means to going where people are, quite literally, into encampments, into street corners. Outreach and engagement require trust building, respect for autonomy, and the ability to meet people's basic needs. Next slide. Outreach starts with basic trust building, and health outreach can deliver care where people are. It has been successfully used for things like vaccination campaigns, including COVID-19 vaccinations, for more sort of relatively simple things like wound care, overdose prevention, and substance use treatment. In San Francisco, we are providing people buprenorphine and actually inducing the buprenorphine for them as they're unsheltered, and sometimes basic psychiatric care. As an internist and a practicing internist, I will tell you that it is extraordinarily hard to manage people's chronic illness when they are homeless. And this is why one of the many, many reasons why Housing First is so important. Next slide. When we talk about outreach and engagement, I hear many places sending outreach teams out to engage people, but they have no place to engage people or navigate them to. We found that offers of housing are extremely much more successful than shelter. And just because people decline congregate shelter in no way means that they're going to decline housing. People have all sorts of good reasons to decline going to a congregate shelter, where many people feel profoundly unsafe, where many people are worried about violence, COVID, they don't have privacy, they don't have autonomy, they have to leave during the day. And a refusal of congregate shelter should never be interpreted as meaning that someone will refuse housing. The principles of outreach and engagement maintain once people are housed. We still need to meet people where they are. And we like to say that Housing First is not housing only. And if we're doing this kind of outreach and engagement, it's as important once people are housed as before they were housed. Permanent supportive housing, for it to work, requires ongoing connection. It can sometimes, like in our study, be done by the same outreach workers who met people when they were outside, or it can be done by different ones. But to do this, we need partnership with healthcare organizations. Most of the services that can be provided in permanent supportive housing are now billable to Medicaid, even more so with the new CalAIM Medicaid waiver. But often housing organizations and nonprofits don't have the ability to bill Medicaid and really rely on partnerships with healthcare organizations to provide these services. Next slide. And I think with that, I will stop and look forward to the panel. Thank you.
Thank you so much. And my name is Medell Briggs-Melanson, and I'm the Chief for Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System, as well as an Associate Professor of Emergency Medicine at the David Geffen School of Medicine. But before I start, I want to go back and make sure to highlight the brilliance of Dr. Ricky Bluthenthal. And so he said he wasn't a physician, but he is just a brilliant mind and has been such a leader in the space. So I wanted to make sure to definitely highlight him. And thank you so much also to Dr. Kuchel with all of her comments as well as Dr. Randall Kuhn. And so what I was asked to do is speak a little bit about that intersection between homelessness, but also healthcare, and especially at a health system level. And I wanted to first start off with sharing a slide that was actually put together by our director of the Homeless Healthcare Collaborative, Brian Zenner-Keating, which really highlights some of the healthcare inequity contributors to homelessness, and most importantly, the bidirectionality of this. And so when we go along this diagram here, we see that things such as worsening physical and mental health, inequitable access to overall healthcare, inequitable access to mental care, as well as behavioral health, discriminatory care and racism, and exposure to trauma. All of that contributes to homelessness, but then homelessness can also exacerbate each and every single one of these contributing factors as well. So it's all integrated, it's all intricately connected, and we can't address one without addressing the others as well. Next slide. And so when we think about healthcare alone, one of the most important aspects that I feel is that we have to think about overall the social structural drivers of health, because we can't achieve health equity or social justice without understanding the aspects that feed into each one. And so these are also known as the social determinants of health, but I like to call them the drivers because they can either accelerate one to have a greater health and sense of wellness, or they can actually prevent an individual from actually attaining a sense of health and wellness. So when we go around this diagram here, we have things such as economic stability, one's employment, income, or debt level. Education, their access to achieving a high achievement rate, meaning certain degrees, which then actually tracks back to their economic stability, but even having access to quality education in their neighborhood. And then neighborhood and physical environment. And that's what we're really focusing on today. But of course, it's also very much connected to all of these other social structural drivers of health. And so when we think about housing security, whether one has housing or not, it's not just that also. It's also housing safety, meaning the safety of the structures. Are there environmental toxins in that structure? What about the physical environment of that area, which may cause them to leave or not? And then we go directly into food and food security in the community and social context. And so one of the things that we just saw was that Randall showed the disproportionate rates of those that identify as Black or African American who currently are experiencing homelessness. And this is a direct driver of systemic racism that has impacted so many different areas of our society, which have caused African Americans in particular to have a much higher rate of homelessness throughout our entire country. But that also plays a significant role into one's overall health and well-being. And then healthcare access and quality of care, being able to directly access insurance to see a provider. And then is there a provider even in your community? And then last but not least, which I like to call the seventh social structural driver of health, which is technology. We are currently living in a time in which technology is normally the route and the pathway to so much more when it comes to economic opportunity, health, education, and also additional services. But if you don't have access to those devices or to the internet, whether it's broadband or Wi-Fi, or if there is less literacy of how to use the technology appropriately to navigate, then that can absolutely compromise your overall health and well-being. So I wanted to just take a step back and make sure that we're looking at this holistically and really driving in on how this actually does contribute to many of the situations that we see with those experiencing homelessness. Next slide. So what can we do about that? Well, one of the things that we did within the UCLA health system is that we ourselves were very concerned about our patients' experience and wanted to try to identify what more that we could actually do. We actually did our own internal study on all the patients that were experiencing homelessness that presented to our emergency departments. And what we identified was that about 85% of all the patients that presented to our emergency department were coming in with either medical conditions that could easily be treated in a primary care setting or urgent care setting, or they were coming in for social services. And the remaining 15% actually needed to be admitted. But as we carved out even more of those different diagnoses, we recognized that many of them were ambulatory sensitive conditions, meaning if the individuals would have had health care and consistent health care, they may not have worsened and needed to actually be hospitalized. And this was both for some of the physical health and the mental health pieces as well. And so one of the things we started to think about is, as a whole, how can we impact this? As a whole, how can we leverage our healthcare assets and our structure in order to address not only the various different health needs, but also how to supplement all of the various different social services in order to ensure that our patients' needs were met socially as well. So some of the items that we continue to brainstorm about was, first, acute outpatient medical needs, acute psychiatric and behavioral health needs, and intermediate medical and behavioral health needs. And we brought together many of various different experts and specialists in all of these areas. And based off of our experiences, not only within the health system, but also from providing care throughout greater Los Angeles in streets and in shelters, then trying to brainstorm what can we actually do. So when it came to acute outpatient medical needs, some of the initial ideas were mobile clinics. And so we just heard about it's so important important to actually meet patients where they are. So guess what? We have to go to where they are. But then also making sure that there was a robust emergency department, clinic, and hospital follow-up. So when someone who was unhoused is actually discharged from one of our facilities, making sure that we are able to follow up with them within the day or within 2 days to ensure that they're not having a clinical decline, to they have their right medications, and just to make sure that they're doing okay and on the right path. But then also having to think even broader than that. We know a lot of our patients, as previously mentioned, have a lot of chronic conditions or need specialty care. So how can we actually develop new clinics that are integrated with both primary specialty care, but also social services? But then, of course, going into the acute psychiatric and behavioral health needs, other ideas such as a sobering center or psychiatric observation units. I'm an emergency physician, and of course, we take care of people that have various different forms of psychiatric or behavioral health needs every single day, and also those that are experiencing homelessness with these conditions. And sometimes people may just be off of their medications, or their medications were stolen or lost, and they just need some additional support to get them back stabilized. And so we do that, and coupling that with additional housing placement services and other social service referrals, then we may be able to help to start moving the needle. And then also, of course, with short-term recuperative care centers was an area that was identified that we need more of. And I know Margot's an expert in this area, but just how can we address the health needs while also addressing their behavioral health and also social needs all simultaneously? Next slide. And so one of the things that we are currently doing within UCLA Health is starting with that acute care phase. And so wanted to just introduce you a little bit to our Homeless Healthcare Collaborative, community partner care directly to our community. Next slide. And so the overall mission of the UCLA Health Homeless Healthcare Collaborative is to promote greater health equity and improve clinical outcomes for people experiencing homelessness. And again, health equity, thinking in mind all of those social structural drivers that contribute to health equity. And the idea behind this is to improve access to comprehensive, high quality, equitable care and social services, and making sure that we are greater assistance on navigation through a lot of these tricky healthcare systems or health delivery models that patients oftentimes have to go through. Next slide. So we could never do this alone because, as we all know, this is an issue within our society. And so healthcare services, and even we of what we're doing, we're only one small slice of the pie. And the only way that we can identify the gaps in need and address those gaps in need is that we partner with so many others that are so important in this space and that have been doing this work in both health as well as social services, so that we are all able to collectively make the greatest impact possible. And so what this slide actually shows is a few of those various different partners that we have had the privilege to partner with already. Of course, outside of the UCLA Health, one of our really important partners for us is Venice Family Clinic, as well as now also the Community Clinic Association of LA County, partnering also with city and county health and social agencies, as well as those community-based programs that are completely dedicated to this work, as well as researchers and public health officials, students and trainees, and philanthropy in order to help to support more of these efforts. Next slide. And so what is it that we can do? Well, currently right now, underneath the Homeless Healthcare Collaborative, just focusing on those acute care needs before we get into others, we've actually in the process of a 3-phase program, where phase 1 we call Transitional Primary Care. And this phase actually started last month in January, where we have vans that are actually launched out to various different areas of Los Angeles, including North Hollywood, downtown Los Angeles, South Los Angeles, and West LA. And the whole purpose of these vans is actually to provide urgent and primary care services to those that are in need, and also just to identify any geographic gaps that are there that our vans can actually go and provide services with, in partnership with other social service agencies, community-based organizations, and even other healthcare clinics. Phase 2 will be launching by summertime, in which we'll be expanding the fleet of vans, but really doing this in what we call a high-tech, high-touch manner of really making we have the greater scope, that we are able to provide and fill in any gaps of care, whether it's specialty care, behavioral health services as well, going directly to our patients, but then also being able to have our providers in centralized areas where they can also do direct video assessments, even if they're not out in the field when the rest of the teams are in the field. So that's one thing that's really important for us too, to be able to have as much greater scope as possible to fulfill all the various different needs that are there. And then, as we mentioned, sometimes people do need higher level of services such as specialty care. And so we want to make sure that we provide that access to cardiology or gynecology or podiatry that we know so many of our different patients have. And so this idea is going back to that integrated model, providing the specialty care, but making sure that we also have all of the availability of social services. So housing placement, but also job opportunities, legal services, and any other type of immigration services that may be necessary as well. Next slide. So these are actually two pictures of our vans that are most recently deployed. And so these are medically equipped vans that provide medical services directly to our community. On these vans, we actually do have a pharmacy, which we can provide medications to our patients right when we see them, or we can dispense them as well. And there's also lab capabilities on each one of the vans. The whole idea, again, is to make sure that we're increasing accessibility to high quality primary and urgent care services and making sure that we're removing those barriers that people often feel if they're living in their encampments or living out in the streets or in shelters, where we're coming directly to them and making sure we're able to provide them the care that they need. And they know that this is consistent, we'll be able to come back to them, while also making sure that we get them in to their primary care providers if they're already impaneled to a primary care home. Next slide. And so how does this actually fit, especially as a larger health system framework? I wanted to just show this because the Homeless Healthcare Collaborative and all of the various different phases actually fits into a much grander vision of how we continue to promote greater health and social justice within our community. And you see where the Homeless Healthcare Collaborative is, and I don't have time to go through so many others, but these directly tie into many of our other system-wide initiatives, such as really focusing on social determinants, screening of all of our patients and providing them the resources to address any inadequacies when we actually do address their social determinants. But even things such as we becoming an anchor institution and making sure that we are thinking about how we continue to feed into our communities, build stronger partnerships in order to support greater economic, social, and physical well-being, especially for our most under-resourced populations. And then also really centering the importance of workforce diversification and development, because we know that it's important from our research, from our evidence, as well as from just real life. We have to make sure that our workforce represents all of the various different populations that we serve. And so that's a really important aspect for us right now as an organization. And so that I will stop there because I know that we're going directly on over to the panel, but I thank you all for the time.
Thank you so much for our panelists and to all of our panelists, but it's really exciting to hear about the plans that UCLA Health has. So thank you, Medell. And I've had a chance to see how these have evolved over the last few months, and it's really exciting to see. I have a bunch of questions, but we had a couple people recently asked questions that I share, which is I just wanted to start out by talking about some of the Medi-Cal reforms, particularly around CalAIM. And I guess that is, how have these, let me see if I can phrase this right, how have these enabled the opening up of new services to be provided, and what reforms do we still need?
Medell, would you like to answer that, or?
Sure. I know I was looking at you too, Margot.
Yeah, I didn't know.
We were both looking at each other. Well, I think all of us are very excited about all the new CalAIM initiatives that are coming on board. And I think that there's still some, we still have to see exactly how they're going to unfold. The most important thing about CalAIM, which is exciting, is that able to have additional funding in order to build out the greater infrastructure, the greater networking, the partnerships between the healthcare services and the social services, and really think about some models for Medicaid reimbursement. I must say, I think it's still early. I'm still learning a lot about it myself and trying to see how it's going to unfold. And so, but I think there's a lot of potential, but we'll have to see where it is and then see still where the gaps are, and we'll have to move forward from there.
Yeah, I would just add, I think exactly as Dr. Briggs-Mountain said, sort of, we'll see how it's implemented is going to be the big thing. I think some of the promise is the ability to use Medicaid dollars for some more housing adjacent services. There has been a total black line between using Medicaid dollars for rent. And this doesn't take that down, but it loosens it a bit so that CalAIM should make funding available for certain like housing navigators. So those are traditionally like folks who help people use a housing choice voucher, often called the Section 8 voucher, people who can help look for housing and sort of negotiate with landlords on clients' behalf. It will potentially allow for some like first and last month's rent, sort of a down payment on rent. And there will be ways for, as you probably know, in California, all Medicaid is done through managed care plans that go by the county. For some Medicaid managed care plans to use some of their capitated money if they're sort of for some housing services, for instance, in lieu of skilled nursing facilities and things. So it sort of loosens a little bit of the dark line between what health dollars can be used for. And I do think, I have to say, I'm spending a lot of my time with the non-healthcare systems who are working with people experiencing homelessness. Certainly one of the struggles that they have is like they don't have any experience billing Medicaid. Like that's something that we in health systems really know how to do. And I think perhaps that's an opportunity for greater partnership where it's something that health systems really know well how to do and housers don't. And to like help us all and to help staff appropriately so that people get the services that they need, I think is going to take some partnership.
Yeah. And of course, in LA County, that does involve working with, I know I semi-regularly speak to, I think, 7 different healthcare providers or insurance plans that are all bringing out some kind of ambulatory capacity to deliver services. Some are starting up new, managed care or new joint practice groups with different models for physician referrals. And of course, some are enrolling people on CalAIM. I guess, let me ask Dr. Briggs-Mallinson one more question. Kind of how will UCLA try to work with all these different organizations, and is it sort of blend into the chaos or ignore the chaos or try to bring order to the chaos? Is that even possible?
I would say, well, the first thing that we really center ourselves on is partnerships in every way. And so I think part of this is the stance we've taken is that we know that we have certain services that others may not. Because we're an academic medical center, we tend to have a lot of specialists, of course. And so really trying to partner with all of the other groups that have been in this space that are doing this work as well, of saying, where are the care gaps? So do we have a care gap of getting people in to see this type of specialist? Or do we have a care gap with some of our more chronically complex patients? And what can we do to help? So one of the most important aspects for us is to really make sure that we are not causing redundancy, but if anything, expanding the horizon and the various different accessibility to greater services that we know many of our patients in Los Angeles do need. So that's where our positioning has been. And so you're right, when it comes down to all of the various different people that are involved, we're right now just in the process of just walking through with everyone and just saying, where can we actually provide the most assistance and the most help, and let's figure out those different models of how we can achieve that. And of course, with the additional supplementation from CalAIM in the future as well.
Thank you. Now I'd like to switch gears and talk a little bit about substance use, and that is we had a couple challenging questions in the Q&A uh, uh, around the relationship between sobriety and permanent supportive housing, and how and I think that is, while recognizing that sober is not a choice and is a continuum of experiences. I'd like to ask what are some of the challenges of relating to permanent supportive housing and sort of serving a mix of people who aren't substance users or are substance users or are on a path to recovery, and how best can we manage that, and what is our body of evidence for how best to do that? And maybe I can ask both Margot and Ricky to address this.
Well, I mean, I think one of the first places is to make access to the available medication treatments easier for people. You know, we're in the midst of a transition to fentanyl in the opiate market in Los Angeles. And that's one of the reasons why we've seen, and in the state of California, the increase in deaths among African Americans. So in a way, there's sort of a moral imperative to make the medication treatments more widely available to people, and then also make the kinds of ways that people use it broader. And so what I mean by that is sort of two things. So one thing is, because of the way insurance works, even in the Medi-Cal situation, the types of preparations that people have for receiving buprenorphine or Suboxone, as it's more widely known, is pretty limited, sort of 3 levels of dosing and then sublingual. And the truth is, you know, we live in a country that's got 24 different brands of aspirin with, you know, a half a dozen different dosage and, you know, multiple different delivery systems. And we kind of need to open that box up and sort of say, hey, we have these medications. We should do the same thing with methadone. How do we make them more widely available to people? So folks who are ready to either stop or to manage their opiate use can avail themselves of these really highly effective medications. So I think that's one thing. I mean, I think the other thing is that we need to take seriously the needs of these populations. And what do I mean by that? Hey, if someone is on a path to recovery that requires that they be in a sober house with other people who are abstinent, then let's put them in those places and not put them in places where that's not the case. Let's also house them in neighborhoods that aren't overrun with drug use and drug sales. I had an interview with a person who was using crack cocaine years ago, and he was housed at the time, and he said it was so in downtown in Skid Row, and he would look out the window, and he described it was almost like a concert scene of the lighters coming on as he saw people using crack cocaine. Like, so that wasn't a good place for him to be housed. So I do think we need to take seriously the needs of people, all of them, whether they want to continue using, whether they want to modify their use, whether they want to be abstinent, and then give them the housing options that support that. One thing, and let me just finish with this thought real quick. The things that we require of people to obtain treatment are not well thought out, right? So, giving an example I like to use, I've been happily married for nearly 24 years. If I had a medical problem that meant that I couldn't see my wife for 6 months, I'm going to keep having that medical problem, right? So we need to take seriously the needs of the population. We need to have modalities that are available that can accommodate. Hey, someone has a partner. Hey, someone has a pet. They need housing. Maybe they'll do treatment and housing, maybe they won't. But we need to really open the box and realize that their human dignity, their well-being needs to be honored just like mine is. And not use the accidents of our political economy that drive people into homelessness as an excuse not to provide them with the same things that we would want for ourselves or our families.
1,000% yes to always brilliant, Dr. Bluthenthal. So thank you for that. I mean, I think we often say you know, the roots, I say all the time, the reason we have such a horrendous homelessness crisis in California is really three, right? It's our deeply rooted structural racism that we seem like just absolutely like we want to have all these conversations about drug use and don't want to have conversations about the roots of the ongoing sort of structural racism, which continues to this day and which really set us up for this. The second is, and these are all interrelated concepts, the devastating lack of deeply affordable housing. In California, we are the second worst state in this nation. We have 24 units of housing that is affordable and available for every 100 extremely low-income households. An extremely low-income household is any household that makes less than 30% of the median income of their area that they live in. We are 1 million units short of that. And we will really never solve this problem unless we do this. And exactly as Dr. Bluthenthal said, like the perturbations and the way that we wrap ourselves around really relate to that. And the third is the glaring income inequality. Those three things are all related and intertwined and from one another, and they contribute to it. Supportive housing doesn't necessarily mean like a building where everyone lives together. In most parts of the country, in fact, it's what's called a scattered site. It's a concept. It means that your housing is subsidized and you have folks who help you maintain that at whatever need you look at. I have a physical disability, and I think of the supports that are offered to in supportive housing as I think of like a wheelchair ramp, right? Or an elevator. A wheelchair ramp or an elevator are the accommodations that allow someone with a mobility disability to live in housing. For people who have behavioral health disabilities, they might need some case management or some support to help them thrive there. But it is not like necessarily a physical structure. And once you sort of break that away, and once you recognize people's autonomy and that we need to meet them, housing first doesn't mean that you have to live in a building in downtown LA or Skid Row or in the Tenderloin in San Francisco where I am, surrounded by triggers, right? You could live in the community with the supports that you need. We're seeing some interesting places like Portland, Oregon is grappling with how to create housing that is available to people who want to be sober. What you want is because substance use can be relapsing and remitting, you don't want the fact that if they relapse, they then are back on the streets, right? So you need to create a system that both creates those opportunities for people to live in places without triggers, place where they feel supported in their sobriety. But what Housing First says, really the only thing it says is it has not, that's awesome, but you just don't want it to be that if you do then relapse, your only alternative is to return to the street. So you can see why that's challenging in some of the sort of project-based things. If like you have a whole building that's sober, and then you have to have enough flex in the system that if someone does go through a relapse and they can't be there anymore, they can be someplace else that is supportive for them. But absolutely, there's nothing contradictory about permanent supportive housing, housing first, and having sober living environments if that's what the person needs. You just don't want the price of it to be that if they relapse, they're back out on the street. And we are so constrained in our imaginations and our options because of these deep glaring inequities. And then as soon as I say that, people are like, but what about the substance use? And I just saw someone, smoking meth on the street and you can't just give them an apartment. And I say, like, you can and you must. And people, many people with substance use disorders can live and thrive in housing, but we just have such a sort of discoordinated system that it's really impairing our response.
Thank you so much to all of our speakers. I know we ran a little bit over time, and so I just want to exercise my moderator's privilege and maybe just, I think, to put a bow on all of this, right? One of the things we're hearing across different phases of the drivers of homelessness and the experience of homelessness is that we live in a society that, for better or worse, is dictated by markets, right? And homelessness, it reflects the perverse incentives and the lack of supply in our housing markets. The experience of being homeless is an experience of being subject to another set of markets, right? So the market for substances that may be readily available in your space when other palliatives and other sources of healing are not available. That's not the only market that people experiencing homelessness face. So I think about processed foods, that if you live a life surrounded by nothing but processed foods with no refrigeration, then that will be the only food that you eat. So the health system is one area where we are seeing a little bit of progress towards reform. And I think Professor Kuchel really described that very well, that we have an incremental set of reforms in the health sector that UCLA is taking the opportunity to implement a new set of changes in how we pursue healthcare for people experiencing homelessness that would involve addressing housing. But ultimately, if none of the other market, right, and that is an opportunity to get people out of this very dangerous space. But ultimately, we need to move forward in all the other markets. So Dr. Briggs Melanson laid out all of those social determinants. We need to move forward in healthcare. We need to move forward in housing. We need to move forward in technology. There's a lot of work to be done. I'm so thrilled that so many of you came out for this. I am so pleased to bask in the glow of our three excellent speakers. And thanks so much to Laura Erskine and her team for organizing this.
Thank you
so much, Randall.
A real round of applause to Randall, to our three speakers. This was an amazing session, and many of you commented in the Q&A and the chat, one of the best health forums ever, and I'm thrilled that so many of you could join us. You know, Paul Torrens strongly believed that the dialogue and discussion that this forum allows for is really what a great public university like UCLA should do. And so I would encourage you to consider making a gift to the forum. You can use your camera app to scan the QR code. And please know that we're grateful for any support. Our next health forum will be a month from today on March 16th. Organized by our very first executive in residence at the UCLA Center for Healthcare Management. And it's going to focus on the impact of the metaverse on healthy aging. So a combination of public health, technology, and healthcare management. So I hope to see you all there.